in it and my books that.
Look, Mama's
And
got
I
some.
got 2 folders for drinks.
Okay.
I got one.
Okay.
One for me.
That's this week. Mama's about to have to teach you. You can't come over there. You cannot do that. You getting ready to go to Mama's side?
Yeah. Baby.
Okay, calm down. Come see.
Hey, Janine. Hey, thanks for tuning in.
No problem.
I have a video from one of our, from Chelsea, which I'll play at the end. Brad is probably going to be a little late. He said he's got a little more complex patient. Said no problem. I think Lindsay said she probably can't tune in because she was so busy today.
Yeah, I talked to her earlier, and I talked to Roger. I see Roger.
Okay, here's on. Yes, I see it now. Okay. So I'm gonna
Hey,
write.
can y'all hear me?
We can.
Okay, I'll be right back.
Okay.
Yeah, we were both at the Baton Rouge General this morning
Oh, okay.
talking about how we might have to do this with masks on, but I guess he found a quiet place like me.
I know. It's definitely, I told everybody, I'm like, okay, so they may or may not be able to join in because most people are going to be super busy right now. It just is what it is. And so I said, it might be a short day, and then we just have like some people send videos in, and like whatever works, we'll get it done somehow. So, you know.
Yeah, I hope I can answer their questions well. It's always fun when there's a big panel because then they get so many different perspectives.
Right. And then it makes you think of something else like, oh yeah, and this and this.
Exactly. And I've worked in so many areas that I feel like I can give a little perspective for different places, but it's easy to build off of other people's comments.
Definitely. Y'all, class, if you have a video, you need to have it on. It's kind of hard for people to talk to just a black screen with a white name written on it. So if you have video, you need to have it on. This is it's pre-PTA, so they're not required to have a laptop with a camera.
Okay.
But I mean, most people do nowadays. Pretty much everybody. If they have a laptop, it's pretty much got a camera. So that's a good thing.
Hey, everybody.
So I'm gonna take and roll real quick. So how are things over there right now? Being the liaison, are you really able to go back and forth?
Well, because we're affiliated with the Baton Rouge General, I'm still in and out of the Baton Rouge General, Bluebonnet, or Mid-City.
Okay. Yeah, I
The
did.
lake quit letting people in a couple weeks ago.
Right.
And same with like Lane, St. Elizabeth, and North Oaks are also my territory. And so we do everything over the phone and by the computer documentation.
Gotcha.
A lot of video calls with our patient. That's been interesting.
Yeah. We actually had to do a video call for my daughter for her ear. And I just kind of said, I know that's not covered in my insurance. And you can't see her ear like through the computer, you know. And I was like, it's going to be a couple days before I can order a little otoscope so that you could see in her ear possibly. And I just kind of was upset and like, could you just call something in? I know it's an ear infection. We went swimming. I didn't clean her ear with the stuff after. And I ended up calling insurance, and they said they're asking providers to waive like any fees if it wasn't covered. And she told me I would not be charged for it. And I was like, okay, well, all right.
Okay.
All he could do was have her like pull on her ear certain ways to see if it was painful, and, you know, asked a little bit about symptoms. I mean, that's all I could do, and had to prescribe her something through a video conference. So it is, they're making it do how they can. So, all right. Well, it looks like it's that time. So we have a smaller class this go round. I don't know if our numbers have kind of decreased a little because DPT now has opened up and probably has drawn some people into that program versus PTA with the current healthcare crisis, and not necessarily this pandemic, but prior to, we kind of started seeing numbers drop down as Medicare's cutting pay and stuff. So we have seen that battle and trying to see like what's causing those issues. So this is a little bit smaller class. I think we have about 16 in here. Brad will probably be jumping on in a little bit, and there may be one other person, Bailey Berg, jumping in. So right now we have students, if you have your video available, or if you have video, please tune in with your video. And we have Roger and Janine both here today to speak to y'all. So we're gonna begin with a quick prayer, and then we will kind of let y'all introduce yourselves and talk to us, just tell us a little bit about how you came to be a PTA and like your journey and what you're doing currently now. And then I sent y'all some of those questions so you can sort of be ready. And I have a couple of them kind of written down that we'll focus on mostly. And we'll go into others if we have a time for that. So if y'all can take a moment. Lord, bless us with your presence today, in that we are able to learn how to grow and become better people. Please, we pray for those who are currently helping others during this trying time and who are on the front lines, we would say, helping to assist with the battle with the COVID-19. We pray for those who are making those decisions for us, such as our governor and president, and we ask that you guide them to make the best choices for our communities and for our nation. We ask this through your name. Amen. So, all right. So, Janine, if you go ahead and introduce yourself and let everybody know a little bit about you and kind of how you came to be in the position you are now.
Okay. Hi, I'm Janine Decker. I'm a PTA. I graduated in the class of 2004. I worked at the Lakes Rehab up until about 2.5 years ago when I started working at Baton Rouge Rehab Hospital. My role changed from being a treating PTA to now I do clinical liaison work. So I go to the various hospitals and I talk with the patients about the benefits of rehab, whether it's our inpatient rehab program, usually that's what I talk about, or our outpatient day neuro program or outpatient therapy services, so that patients can get what they need after a surgery, a stroke, any other kind of injury that might require the therapy post-acute. So I've also done a few other things. While I'm here, once a week or so, I'm usually treating in the inpatient rehab gym, the outpatient gym, or day program gym. And I've also done some home health in the evenings the past few years. That's it.
I forgot to tell y'all prior to Roger and Janine, if you need to get out at a certain time, just let us know, okay? I know you're probably working lunch break for this, so if we just need to do 20, 30 minutes, it's totally fine. Roger, you can go ahead.
So my name is Roger. I work at Baton Rouge General, and I work in both the acute care setting and I work with the lymphedema outpatient clinic. So if most of y'all know or don't know, lymphedema is the swelling of extremities and the trunk and stuff, and usually related to the lymphatic vessels that are affected. And so in that sense, we do a lot of massaging and bandaging and stuff to decompress and try to reduce the swelling in the extremities of whatever's affected. I've been working here. I graduated in 18, I think. So I worked at Sage outpatient for a little while, and then back in 2019, basically the beginning of the year, I started here at the BRG.
And Cherie McAllister is here, so could you go ahead and join in, Cherie, and let us know a little bit? They were just kind of introducing themselves and letting us know how they came to the position they are in today with PTA.
All right. Yeah, I'm Cherie McAllister. I graduated Our Lady of the Lake, or now Fran U, in 2008. I've worked in rehab in Texas for a while, and now I've been back here for 10 years now or so. So I've worked for Women's Hospital. I do pediatrics and adults. I work in the aquatic setting, and I work in a regular gym setting. We do pelvic floor, we do pediatrics, as I said, and we also treat lymphedema patients and just your basic outpatient patient also.
Okay, all right. I keep muting myself to more we have on mute, the easier it is to hear. So then I go to talk and I'm not on. So, all right. So what we'll go ahead and start off with is one of the questions to start off was, what is your most challenging part of being a PTA? So whoever wants to take that first.
I guess I'll take it. I really haven't found a ton of challenges with it. Maybe when it comes to a patient is ready to progress to the next step, and that is not a goal in the plan of care. And so I have to kind of pause what I'm doing in a treatment session so that the PT can reevaluate the patient or write that goal.
Yeah, I haven't really come up with a whole lot of challenges either, because I think I've just been actually blessed to work with some great PTs that we work well together. So we kind of give and take and stuff. So I haven't really come to any challenges. And even this new challenge with the pay decrease and all that hasn't seemed to be at the moment a challenge either. So I really haven't had a challenge that I can think of.
I think challenge for me has been, it's not really a negative challenge, more a positive challenge, is that as a PTA, you can only afford to see a patient, X amount of times or whatever. And so, you get frustrated sometimes when, a patient has to be delayed or whatever because of has to be re-eval or a sixth visit or whatever. So, that can be frustrating as a PTA because, the care is going well and you want to keep it up, and, but that's just part of the game. That's just how the rules are. But it's a good challenge because you want to keep going. You want to keep the patients progressing forward.
Okay. Next one would be, what is some advice to give to the future PTAs about careers and how to be successful?
I'll go. So first of all, don't be picky. Okay, don't be dead set on one certain job opportunity like pediatrics. I'm telling you, pediatrics is a tough one to get into because there's just not a lot around. So having this opportunity to be in school and explore all your options through acute care, through outpatient, through nursing homes, through whatever you go through, that will give you a better a broader field to choose from when it comes down to making a decision about what you want to do in life. So I've always wanted to do acute care. I got lucky. This job opened up and I love lymphedema. It's something I got certified in pretty much straight out of school. So I got lucky with this one. But it's, if you have broad options, keep your options open.
I would say the same thing. Definitely be flexible. If an opportunity presents itself and you don't think that's something you'd actually be interested in, go ahead and give it a shot anyway. You have no idea. I never thought I would like inpatient anything. I only liked the outpatient settings when I was doing my volunteer hours. But then my first rotation was in an inpatient rehab. And anytime anyone said, hey, I have this, you want to check it out? I didn't know how I felt about it, but sure, I'll tag along and see. And there were so many things. I really have a passion for helping patients after an amputation, or like Roger said, I really enjoyed lymphedema, so I went to the certification courses. So there's a ton of opportunity out there. You just have to be willing to open your eyes and ears and kind of just be ready for anything. You might like it. You might surprise yourself.
Yeah, just to reiterate what Roger and Janine said, it's pretty much keep an open mind, because I never would have thought that I'd been dealing with anything with pelvic floor. I don't do anything internal, but we do biofeedback and that kind of thing. And then just incorporating it in your everyday activities and exercises in the gym. It's something that you couldn't have told me that I would have been involved with, or even working with cancer rehab and patients that are going through cancer treatment and that kind of thing. My PTA role has just kind of evolved as the longer I'm in it. Like, things have come up. I worked in rehab. I've been in peds. I'm in aquatics. You couldn't have told me I'd have been in a swimsuit half my week. It's Like, it's just kind of what it is, and it's been fun. I haven't had anything that I'm like, nope, I want out. It's just been what it is. It's just ever evolving.
Can y'all speak to treating in a big city versus a small rural area? Have any of y'all been within both of those areas and talk about any differences that you may see there? I don't know if y'all have had enough difference, you know.
No, I mean, my only would be when I did home health and doing home health within the Baton Rouge area or outside of the Baton Rouge area. And it's similar. I mean, sometimes the houses are a little different, or or the people's education level might be a little bit different, but otherwise I haven't noticed anything different. I haven't been in like a hospital where it was a small hospital versus a large hospital.
I can say, like, when it's hard to, because I haven't really had the same experience either, but for outpatient clinics per se, I worked at an outpatient clinic as a tech out in Prairieville. So a lot of these outpatient clinics, especially in small towns, you know, people come and go, but you kind of see the same face over and over and over, and you kind of develop a relationship. But when you get to a hospital setting, whether it's a small town or not, I feel like the hospital, you just get, you know, a variety of people, and you may see some of them frequent flyers or long stays or anything like that. But I think it's more so almost what kind of clinic you're working in. I think you develop a lot more relationships with people on an outpatient basis versus inpatient, where you might develop some, but for the most part, you'll see a variety of people, you know, constantly throughout your days and careers.
And I've worked in Baton Rouge and then in Beaumont, Texas. So they were very similar as far as, you know, the inpatient setting versus outpatient setting. Yeah, you just kind of get more relationships with people in an outpatient setting, because like Roger said, you have the frequent flyers and those people that come back in, and you get to know their families and things like that. But in the inpatient setting, it was, you got connected, but it was on a shorter span, but you just didn't have as much time to keep up with them.
And I'll chime in too. I sat in on DPT's has Wednesday Wisdom, and they had some speakers from all around the country. Just people from China talking, people from Chicago, Florida, all these people on the conference the other Wednesday, and they did speak about, there's somebody, he was in, I'm trying to remember if it was New York or Pennsylvania. I think he's in Pennsylvania right now. But he said that area, I mean, everything shut off there. They cannot do any like some of the outpatient clinics here are open and on a limited basis, patient-wise, that's coming in, but there is nothing at all. They won't let them do anything. So like, people are too scared right now. So that can maybe a little bit speak to big city versus a little bit more rural that we're in, and how their mindsets are. Things he said there were getting to where it was wanting to see their patients a little quicker and that overhead on it, and he ended up opening his own practice because he liked a 60-minute eval and a 30 to 45-minute minimum of a treat, you know. So I think it's all in mindsets too, on how you see things versus and how much you'll push for your patients, you know. I think so. That's a little bit of what was happening up north. Okay, so they also want to know what's your suggestion for the best continuing ed courses, and you know, what do you suggest is probably some of the better ones to go to?
I would love to go ahead and tell y'all neuro. Neuro is such a hard one to learn and to understand and incorporate into your practice. Because coming straight out of school, my last clinical rotation was Sage Outpatient, like I mentioned earlier, and they hired me as PRN, like basically right out of school. And so it's super difficult. So neuro courses, anything neuro related, stroke wise, especially, you know, stroke patients is, you know, you see them almost every single day, especially in the hospital. Neuro courses is super important. Specialized courses are difficult because if you don't find exactly what you're looking for in terms of what you specialized in, yeah, it can be hard. But there's other courses taping and stuff like that, like the general stuff, yeah, it can help in any kind of setting you do. But yeah, I would say neuro is a big one.
I definitely agree with Roger on the taking neuro courses, but that was one of my favorite patient populations, was anything related to stroke, head injury, and spinal cord. But working at the lake for so long, and now working affiliated with the Baton Rouge General, if your facility is hosting a course that's going to be super cheap to you because you're an employee and you can afford to take it because it's only $50 for the weekend or something like that, even if you don't need the credit, I would definitely take any extra courses as well, because it gives you insight into other areas that you may not have thought that you were interested in. Like Cherie was saying, I never thought I would have been interested in pelvic health, but they brought a women's pelvic health course to the lake while I was there. It was $50. It was a Saturday and a Sunday, and I really, truly enjoyed it. And she's right. I incorporate a lot of pelvic tilts and other things into just general mat exercises. So definitely, I would take anything that you can afford to take, especially right after school. It gives you the extra education.
I would say anything that helps you kind of bridge that gap between experience, like graduation and then your experience, because there's a gap there when you first graduate that you'll feel like, I don't know what I'm doing, those kind of things. So anything that you feel like in the setting you're working in that would help you just get more comfortable and gain more knowledge. I didn't like shoulders right out of school. I did not like shoulders at all. And so I took some webinars that had little, what they called like little nuggets of information, little gems, and you can kind of go back and like use them. And sometimes it just gives you the confidence because you talk to your PTs and your other coworkers and you're like, hey, I learned this, and like, oh, that's really cool. So then you just kind of, it just builds upon everything else, and it just helps you feel more comfortable in your setting.
And I see that Brad just came in, so I'm going to unmute you if you're there, Brad. I think I am.
Hey, I'm here. Hold on. I'm just trying to.
No problem.
Hey,
So,
everyone.
good morning. I guess you have a busy day going on right now, huh?
Well, I had a patient that is a new patient, and it's funny. I came in right talking about neuro, and it's a stroke patient that required just a lot of hands-on work just to even take. We're attempting to take a step, and just has a lot of foot position problems and lack of strength. So it threw my schedule off a little bit.
Well, Brad, can you do a brief little introduction about how you came to be a PTA? And we've already talked about something that's most challenging and advice for the future PTA. So you can throw that in there too if you have it.
Sure. Well, I had a very unorthodox path to being a PTA. I got out of high school, went to college, and was all fired up to go to med school, and then realized what it actually took. And so I said, not for me. So then I started pursuing nurse practitioner because that was a real growing field at that time, and got to nursing school and absolutely hated life. So was kind of lost for a little bit. So went to work, went into sales, and did that for several years until I had the opportunity living out west to go to a PTA program at Loma Linda University. With my previous coursework, I could finish in about 18 months, I think is what it took, 15 to 18 months. And went immediately after that outpatient. And then, so you see my surroundings here in the car, I'm doing home health and have been for my 11th year of home health. One of the biggest challenges that we face is in the home setting is sometimes the lack of equipment. So you have to be really creative with exercises and how to get people moving and mobile when you don't have a set of dumbbells or a bike they can ride or something like that. So you have to be real kind of on the fly thinking there. But the second part was what's most rewarding. Is that right, April?
Advice that you could give your PTA.
Advice is to always push yourself, again, kind of coming in mid conversation. Any extra courses, any extra training you can do, jump on it with both feet, because one of the biggest things that has helped me in my career was vestibular training, because I've run across so many vestibular type patients that I can help treat in their home and actually see the results that when they themselves maybe didn't even know what was going on. So, and that would not have been possible without taking those extra courses.
Okay, so Brad, the other question we talked about was big city versus small rural city. Do you see a difference? I know because you kind of practice in a couple different areas, difference as far as the population, what people expect of you and how things were sort of run?
A little bit. I find that sometimes in bigger cities, either the patient is in a bigger city or is from a bigger city. Occasionally they will get the sense that somehow we work for them, and yes, they are our patient and we want to do better, but at the same time, they're not our boss, and they forget that sometimes, that they don't think that they need to listen to the expertise that we're trying to provide. But again, that is by far the exception rather than the rule. Now, of course, being from a small town and working in areas that are more rural, you have to be careful because they will try to fill you up with coffee and cake and every other kind of snack there is, because they're so appreciative. Not that other people aren't, but just that old kind of way of hospitality. You'll sit there with 30-minute conversation about who your parents are and what they did for a living before you can get into your treatment.
Yeah, they take a little more time to build trust with, I think.
Okay, so I think y'all sort of talked about the best continuing education. And Brad, do you have anything to add to that either? Which courses you felt were the most beneficial, or like which institution you might have went to some continuing ed for that you found were most beneficial?
For me, I've kind of done a variety of things. I've gone to the state meetings a lot because even though a lot of times it focuses more on things not necessarily home related, it gives you a refresher on some orthopedic based principles that can be used and translated into the home setting. I'm exploring a new way starting this year, because my renewal is up next year, that it's a company that provides for one flat fee, and if I sound like a commercial, I'm sorry, but that you can get all your online through them, and they do kind of 1 and 2 day seminars, and they are more focused on home care. So that's something that I'm really interested in. As far as what's been most beneficial to me, by far it's been the vestibular and the balance training, because in the home health setting, that's the biggest challenge by far. Besides generalized weakness is balance that we run into on a day in and day out basis.
And I think all of y'all have done home PT, maybe except for Cherie, possibly. I don't think you have. So this
I haven't
question,
done home PT.
and Roger either. Okay, so Janine and Brad on this one, but you've kind of talked about it already, Brad. Drawbacks to home physical therapy. Any drawbacks that you would want to add to that, Janine, of doing home health?
Coming from a rehab world most of my career, going into the homes in the afternoons was a little bit harder, because you will have a more difficult patient, like a stroke patient, who you really want to do these big things to kind of what they call wake up their system, but you only have your set of hands. You don't have a second set of hands with your tech or your OT partner or something. So it is more challenging sometimes to give them what you feel like they need, because you're limited with resources in the home. It's not just an equipment resource, because sometimes you can, make a standing frame at the sink or something, but it's also just being able to be more mobile away from some of those structures, and try to get them to take that step, try to get a family member to help you where it's safe for everyone. It's a little bit, I find, more challenging in the home whenever you have a more difficult patient and you don't have a helper.
Yeah, sure. All right. So they just talked about, or last week we reviewed it was Good Friday, and because of the schedule change, I ended up having to voice over the presentation on different settings. So they were learning the differences between an inpatient versus a rehab versus sort of like SNF, long LTAC settings. So if you could sort of talk about the different settings that you've been in and maybe why you would prefer one versus the other, to sort of give them a little bit more description about how each setting sort of differs.
I'll go. So I can speak on acute care because I've done that for years as not only a tech, but as a PTA. Acute care, again, it's ever changing on a daily basis pretty much. I mean, okay, like I said, you got people that stay longer, so you may see them a few times, but generally when it comes to acute care, your primary objective is to mobilize patients. A lot of these patients stay immobile for most of the days, and then that's where you develop atrophy and pressure ulcers and all that kind of stuff. So we very adamant about getting them up, getting into a chair, doing some exercises if they can tolerate all this kind of stuff. But we're basically like the groundwork. We start the basic stuff and get them going. And then when they discharge, then they'll head to somewhere like inpatient, where Janine will talk more about that one. And then on the outpatient side, at least for me, like I said, the lymphedema clinic, we see people who have swelling and we treat them, and they are, what I talked about earlier about relationships. This is where I see my people a lot. I'll see them for 20 visits, some, more than that if they're really, really bad off. But we're always having to identify garments for them to buy and the best way to tackle their swelling and stuff like that. And even some of the patients have outpatient therapy. So whether they do it before or after, they're constantly, having to switch between getting wrapped and then taking off to go do exercises or something like that. So at least from acute care side and lymphedema, that's what we do.
I'll go next. So inpatient rehab is a continuation of therapy outside of a hospital. It's kind of a bridge program when they've had an injury of some sort and they're not quite ready to go home. It would be difficult for their family to manage with their significant need and functional decline. So rehab it's still a hospital, so they still require the need for 24-hour nursing care and the doctor's daily visits. And they usually need to have the somewhat endurance to be able to do a 3-hour program. It's not all in a row. It's usually split into like multiple sessions, maybe 3 or 4 sessions a day over the different disciplines. If they need PT, PTA, or they'll have an occupational therapy session to work on more functional mobility and ADLs, and they may need a speech therapist for cognitive or communication, swallowing deficits. So with that being said, skilled is very similar, except for they don't have to have a medical need to be in skilled. They do have the 24-hour nursing care, but they don't get daily doctor's visits. The doctor might pop in on them once a week or every other week. And that's usually for a patient who also maybe cannot participate in the 3-hour program. So they usually get 1.5 hours to 2 hours of therapy during the day. And there's a couple of skills in town, like Mid-City has a hospital setting skilled, but most of them are all located inside of a nursing home. It's usually a wing of the nursing home called Rehab to Home. And then here at Baton Rouge Rehab Hospital, we have what they call outpatient rehab. And it's similar to outpatient therapy clinics where the patients, come in a couple of times a week for their therapy, but it is definitely more of a continuation of what they were doing like in the acute care setting or in the inpatient rehab setting, where they're focused on gross motor skills. They do some fine motor activities as well. They're still preparing them with balance, functional endurance, and things like that. Whereas an orthopedic outpatient may be more sports injuries and back injuries and such like that. So a lot of our outpatient rehab patients, they still need a lot of assistance. They just don't need to be in a hospital anymore for that therapy.
Oh,
And for me, my 2 fields have been outpatient orthopedic, which Janine did such a perfect job of describing what we did. And then I made the transition to home health, where the challenge there is not to get them back on the field or on the court. It's to be able to build enough endurance to stand and wash dishes, to cook a meal, to get in and out of bed without as much assistance or no assistance. things that are, the big term we use is ADL, activities of daily living. And that encompasses everything from the time their eyes open till the time they go to bed that you would do in the home that we can take for granted, whether it's reaching up into the upper cabinet to get a coffee mug, or walking in the working in the flower bed because that's something that they're real passionate about. So a lot of balance work, a lot of general strength work, but at the same time trying to temper that where you can't go in and expect to have a high level, high intensity kind of program.
Chime in on that, Brad, and ask you, besides, to your knowledge, besides having to, what qualifies someone for home health versus outpatient? To my knowledge, we know that they couldn't drive or they don't have transportation to get to outpatient facility. But are there any other overhead things that sort of, probably Medicare more rules and stuff? I'm just not as familiar with home health because I haven't done that one.
Sure. The rules are that it has to be a taxing effort or unable to leave without assistance. Now, the exceptions are obviously doctor's visits. They can get out and go to that. Go to church. Believe it or not, they make exceptions for go to the hairdresser. So as long as they're not going out and go and play bingo every week, or even some on the opposite side, we had a man that could not drive, and his only outlet to the outside world was that he was picked up by Council on Aging by their van. He did not drive, but because he went Monday through Friday, Medicare said, therefore you are not homebound. I tend to disagree, but that's the Medicare rule. So we have to play by the rules. But for the most part, they don't have to be on lockdown per se, but it has to be somewhere where it's either by definition a taxing effort to leave home, or they do require assistance.
Okay. All right. So that's what I still had information wise to them. And then obviously, if somebody's like a cancer patient, that it would be at a high risk for them to get out, or infants at high risk would be my other two options. So, okay.
Right.
Sheree, any things to add to, you've got the aquatics and peds and women's health to add to that?
Little jack of all trades. But we also do cancer rehab too. So some of these patients, and the population in the outpatient clinic I work in is not your typical athlete or student or any of those type people. It's a older population, even though we are connected to a fitness center. So we try to get them back to their prior level of function, whether it's gardening or it's running, or even something just doing their activities. A lot of them are going through cancer treatments at the moment, so they are decreased endurance and have other issues and stuff that they're dealing with. So we work on that, regaining endurance, range of motion after surgeries, even if it was a surgery related to their cancer diagnosis, or even kids that we're working on just gross motor, or just trying to get them to have activities that they can do, whether it's in school or just meeting their gross motor milestones or anything like that. So, I don't know if that totally answered your question.
Yeah. All right. So the other question that they had was, is it echoing to you?
Yeah.
A little bit.
That's weird. How free are you to be creative within your plan of care? So how much overhead, I guess, by the therapist do you have on top of you? Are you able to kind of go with the flow with your own ideas? I think they're looking at to see how much freedom you have to come up with your own things for your patient.
So in acute care, you're free. You do what you want. I mean, there's obviously a plan of care to follow by, but if you feel like the patient's doing well, you obviously don't want to push the boundaries of what the plan of care says. But if they can start doing a little bit of something you think they're showing the ability to do, give it a try. Like this is the PTA still has the freedom to kind of manipulate their therapy as long as they're kind of staying within the plan of care. And then, because every day is different, the patient's going to change, the status is going to change every day. I had a lady yesterday who could formulate a full conversation with me. She could move a little bit. Today it looked like she was having a stroke. I mean, it changes. And so your therapy has to change along with it. And then as far as the lymphedema clinic goes, I'm considered a certified lymphedema therapist. I am not a PTA to them. I am another therapist. So my treatment session goes as I choose to do it. And I just communicate all whatever I do, whatever results I see, whatever happens, whatever, I communicate that with the PT just to make sure we're on the same page, because she says the same people too. So there's a lot more freedom than you think, but there's still like the regulations with the plan of care and making sure you don't, do anything drastic or radical.
I don't mind going next. I would say the same thing. In inpatient rehab, I felt like I had a lot of freedom, and there were times when we would all be treating in the gym at the same time, and it's a giant gym, but the PT that did the initial eval would see that the patient had progressed since, 2 days ago when they had the eval. And so she'd say, hey, how about the two of us try some pre-gate and gate activities, and I'll go ahead and write that goal for you. And it's still my treatment session, but there's a lot of input whenever you're in a setting like that. So I felt like as much as I had some oversight, there was also is a team effort between me and the PT. So it's definitely very dependent on the team that you have around you. I've heard stories about PTs that were very strict and had very regimented plan of care. I myself
Hold on, y'all.
had a PT, Oh, I've always had a PT that's been pretty flexible, and they've made it like a generalized goal, like, to ambulate 150 feet with the least restrictive assistive device, meaning that I can use anything I want to try to get them to that level, whether it's with a walker and then I can downgrade them to a quad cane and then a straight cane. And, so it kind of depends on who your team members are and how much, I guess, they trust you, building that relationship.
Yeah, I would say the same thing. I think I work with a total of 9 therapists, PTs, and I have some that, they're all great. They all give me a lot of freedom, but pediatrics is probably the most free. Their goals are a lot more open-ended as far as, kind of like Janine said, get them to this distance, pretty much how you see safely fit. On the orthopedic side, I think sometimes the PTs I work with maybe a little bit more wanting with their hands in the treatment, but that's fine. There's some things they can do that I can't do, or things like that, but you just kind of learn to work relationship wise with your PTs. And when you gain trust with them, you'll see that you get more freedom sometimes, and their goals may loosen up a little bit. And if they don't, you just got to work with it.
So for me, I have a lot of freedom because it's the way our structure is. The PT does the initial eval, does the 6th visit, and reassessments and discharge. So there's a lot of telephone calls, video conferences, and things of that nature, that a lot of trust has to extend both ways, that he's trusting me to use my best practice efforts to accomplish the plan of care, but at the same time, use a lot of autonomy to do what I think's best, because he's not going to lay eyes on this patient for between 2 and 3 weeks. I wish I should have turned the camera around though. I would have just, back to our very first question, if you'd have seen the challenges of home health, I just lived through it. I'm in a cul-de-sac in the neighborhood, sitting under a tree to find shade doing this. And this lady next door to my patient comes walking up to my car just to see who in the world I am, because this is my office. So there's that in home health that you deal with. You can't stay in one spot. People will come check on you.
Oh, that's great.
Neighborhood watch.
Anyone else to add to that? I think that y'all spoke on that one. Well, I think that in general, y'all answered all of their most all of their questions. I kind of took them and tried to pick the ones that were repeaters, you know. Students, if is there anything else that you want to ask them, I want to go ahead and let them go because we are very appreciative of your time. I look forward to this one every semester. This is a fun one, a fun class. And I think it helps the students so much to just kind of get an idea. So it's not just Dr. Amy and myself always telling them about something, but to just speak to practicing clinicians and to be able to understand it from other viewpoints as well. So thank you all very, very much for today. I know you can't hear our fake applause.
Sorry to be late getting here.
Oh, no problem. We appreciate it. And look, like I said, I know this is a rough time to be able to ask people to come and do this. So we were definitely thankful for that. And I don't want to keep you the full hour because I know y'all are busy right now. So thank y'all again. And if y'all have anything else to let them know, please do so right now. Other than that, my students, y'all stay on the conference because I have a video to show y'all. And other than that, thank y'all very, very much.
Bye, guys.
Thanks
Thanks for
Good luck,
having us.
everyone.
Good luck.
How do
Let
I
us know
leave?
if you need anything.
Oh, right there.
Yes, thank you.
Bye.
Bye. Okay, so, all right, students. So I wanted to let y'all know that a couple announcements, and then also I want to show you a video. So am I on here still? Yeah. So if you haven't been told in one of your other classes, our dean is asking that we have you have your cameras on during class time. This is just mostly to make sure you're interested in participating and being part of interactive within the sessions. Of course, today, for ease of time, I had it to where y'all submitted questions prior to. Normally we'd have you asking them, but I knew there would be a lot of difficulty with unmuting, muting, and kind of doing that thing. So I think it went well today. Given the situation that we're in and having to do it by Zoom, I felt like it went pretty good. So that's that. So we do want y'all to have your cameras on. If you have a computer that doesn't have a camera, obviously we're not making you go purchase one, but do know when you're in the program, you do have to have a computer that has a camera, a working camera on it. And I have a video that one other person, I think it's about 6 or so minutes, that I want to show you. So I'm going to share my screen with you to give you a little video from her. Let's see if it's there. Give me 1 second. Okay, share screen, this one. Okay.
Hey guys, my name's Chelsea Chauvin. I'm a physical therapist assistant at Baton Rouge Physical Therapy Lake at the Brittany Clinic, which is right down the road from y'all. I have been a physical therapist assistant there since May 2016, so almost 4 years. I have loved every minute of it. I love being a PTA in an outpatient clinic. I'm sorry I could not make y'all Zoom call, but I hope that the questions I answer are helpful to you. So the first question I was going to answer is from Grant. He asked if I thought the education that I received as a PTA prepared me for the current role that I'm in. I think that the education I got in school was phenomenal. I think it prepared me to be entry level. It was the basics. So I knew the importance, like manual muscle testing, range of motion, special tests for shoulder injuries and things like that. So I got a good grasp on all the basics. To prepare me for my current role, I learned a lot from my coworkers and my supervising PT. At BRPT, we work in teams with a PT and a PTA. I have been with Dr. Seth Kaplan. He's my PT teammate. We have been on the team together for the whole 4 years I've been here. And it's phenomenal working with him. He's been practicing for 25 years and he has taught me so much. I've learned so much from him and the other PTs at my clinic and the other PTAs. So I would say that the program gives you a good baseline and a good entry level to start at, but you're really gonna learn from experience and your coworkers. But it's awesome. I mean, I learn something new every day and I love it, right? So it's great. The next question was from Matthew. It is, what are some interesting things that you develop after attending continuing education courses? It depends on the course you're attending. If it's KT taping, then you learn a ton of different stuff to KT tape. I've done KT taping, I've done geriatric balance, I've done pain neuroscience, I've done all kinds of things. And right now, I'm just now finishing a PTA specialty orthopedic certification. That's through Evidence in Motion. My company sent me to do that. I'm one of the first PTAs at our company to do it. And it's been super exciting. It's been challenging because I started in August and I end in May. But it just goes to show that there are higher levels of education that a PTA can get to help them through their career and to help them learn more. And I also have a certification to be a clinical instructor. So you can go and do that as well and still teach. I love it. So there's so many things you can do. And the good thing about the company where I work is that they pay for our continuing education. So that is a huge benefit when you're going to school. I mean, when you're just getting out of school and going apply somewhere, because continuing education is expensive. So if you can find a place that will cover it, that is fantastic. The next question is from Alex. What is the toughest part of your job? The toughest part, in my opinion, of the job is documentation. You have to be concise, thorough, but don't take forever with notes. I mean, you have to do it in a timely manner, efficiently, but you still have to show enough evidence that that patient either needs to continue because they're getting better or they need to continue because they're getting worse. You have to show and prove why that patient needs therapy. And you constantly, I mean, you do that with every patient, especially the Medicare patients, but every patient. So documentation is the toughest part. It's my least favorite part. Obviously, I love the patient care the most, right? But documentation is definitely the hardest. And then I'm going to follow that up with Catherine's question on what kind of documentation do you do as a PT, PTA? Is it online or is it paper-based? It is online at my clinic. Paper-based would probably be easier, but the online is probably, like, paper-based would just be easier because you could get it done real quick. The online requires so much. However, the online documentation requires that we sign off on certain things before we actually sign the note. So we don't miss as much when we do the online documentation because there's more steps for us to follow and like fail safes to make sure that we put everything we needed to put into the note. But I mean, documentation is probably everybody's least favorite part of the job, but I mean, it is what it is. We have to do that to justify treatment, right? And then the last question I have is from Hannah. What is the most rewarding part of being a PTA? It's honestly, it's seeing your patients get better. Like I said, documentation is my least favorite part. If I could just work with my patients all day long and not have to worry about documentation, I would be in heaven. I absolutely love working with my patients. We see between 20 to 25 per team. So that's a PT, PTA, and technician. I see a lot of post-surgicals who come in on a walker, who think post-surgical hips, post-surgical knees, that are like, I'm never going to get better. This pain hurts. I'm never going to walk without this stupid walker. It's never going to get better. And that's just not true. And it's fun to work with those patients and see them progress through therapy and the look on their face when they're done and they never thought that they would get better and they never thought things would get better. It's just rewarding in general, seeing chronic pain patients who have not had any relief in pain and doing things and interventions that help them, and to see the progress they make and the decreases in pain they have. It's just, the whole job in itself is rewarding. I absolutely love it. I wish you guys luck. And if y'all have any questions, I'll give Miss April my email, and y'all can email me with any questions. I'd be happy to answer anyone's questions for email. And again, I'm sorry I couldn't make the Zoom meeting, but I hope this was helpful. Thank you.
All right. So I thought that was a good little video. I'm so glad she was able to do that. She's normally one that can come in and swing on over real quick and jump in on the PTA panel. So Do y'all, I guess, just nod your head or shake your head? Do you feel like that was useful to sort of answer some of those questions? Or, yep, thumbs up or down is good. Good. Okay. So we got a few minutes left, and I think the only other thing I wanted to remind you of, remember your final is cumulative. We have one more class next week, and right now the final looks to be, I think, like 60-ish questions, 65 maybe, if last time I checked. And same format that we've had, multiple choice, some possible matching type answer. I think for time's sake, I don't think I put a short answer. I think I'm gonna probably not do that for time's sake, but I'll let you, like, remind me next class. I'll let you know if we have any short answers. If anybody has any questions on anything, this is the opportunity. We have a couple minutes left. Just let me know if you have any questions. I'll sit on for the next few minutes. Otherwise, y'all have a great weekend. Was everybody, or other question, anybody had any issues with the PowerPoint from last week? Is that okay? Was that okay? Like, could you hear well on the audio? You can unmute yourself if you need to.
Yeah, you can hear me?
Yes.
Okay. What day is the final? Sorry, I don't know if you said that and I just didn't hear you.
No, I don't think I did say it, but the schedule that was sent out, because they actually scheduled the finals, it will be the same time and on the Friday. So it is going to be the week of, not next week, but the following. Let me make sure I get this right. Am I crazy? Okay, there we go. I want to say it's the week of May 4th through 8th. So let me pull up my syllabi real quick so that I'm not lying to you about things. And of course, I'm using, I have like 2 modes because y'all are on a different schedule than my current students right now that are on the clinical schedule. So y'all are different from mine. Let me just double check on this. Oh, looks like the week before that. Okay, let me just, what I want to do is I want to cross-reference this to the schedule that they sent out to us, that the registrar sends out. And what I'll do is I'll post it on the Moodle forum, so it'll send you that email about it. Okay, so I will, just so that I don't tell you one thing and then screw you up if it's a different thing compared to their schedule. All right, so I will do that for y'all to send the date. I'm just writing myself a note. Any other questions, anything that y'all have questions about? And always remember, if you do have questions on any of the material, you can email it to me and then I can send like a Zoom to you or something if you want to do it that way, or I can just type them back in. If it's a short, quick, to the point question, always feel free to do that, okay, to make it easier for y'all.
Another question, sorry.
Yeah.
So this, like this Zoom session, and I see that it was recording, could you like post it so I can like rewatch it? Because I only got like some of my notes down, but like for the answers they were giving us, I wanted to like go back and.
Yes, I can post it. I have to, it's a weird process. I got to put it on a YouTube and then put it on there. So yes, I can post that for you. Post it. And I think I have to post one other one. It might not be for this class, it's for another class. So that's on my to-do list for sure. I can do that. And y'all don't necessarily have, for test-wise either, this is more for y'all's information. There's nothing like specific. What did Brad say about this? Just to let you know. So yeah.
I have a question about the exam. Like what would your recommendation be like for studying for it?
So some of the key points from the previous exams, some of that is on there. And then same thing, go in when you're going in to like your objective part. If you can read that and say, okay, that would tie into this part that we talked about, or I can verbally state an example of that. I always try to think, so this is a 1,000 level course, right? So if you look on the hierarchy of how you build your questions, everything gets a little more detailed. And y'all aren't always at the highest one where it's a lot of detail, where you take information, pulling it here, and then having to create a scenario, right? So you're given sometimes examples and being able to pull from that. So if it says, hey, know the definition of cultural diversity, then and examples, so you would obviously know definition, but then think about how that applies to real life application. So if you can always just think a step above what we're asking, then I feel like you will always be prepared for something. If you can know those objectives and then know, like, kind of be able to give an example of something. So for instance, like last week when we talked about the different types of facilities, of course, stroke could be in lots of those, right? It could be in almost any of those facilities, a stroke patient. But if I give you a specific example, this stroke patient just needs maybe min assist for his walking with a cane, and is independent with his typical ADLs and with dressing, you know that, okay, that person's not in rehab. They're independent with things. They're only just needing a little assist with their gait, so they're probably going to an outpatient clinic. So those are some ways to kind of think about who would fit into those clinics. That would be something to kind of think about last week's lecture. And if y'all have specifics on any of those, on that lecture, if it was difficult, like along the way when you were watching it, if you had questions, just shoot an email to me and I'll either send you a Zoom or I'll answer those directly through an email for y'all. Okay. Anything else y'all need? I hope y'all are all doing well, and I know it's a crazy time, but do you know that what they're still thinking for the summer is that we're gonna start off this type of version type thing? So still know that they're thinking that that's going to be the case, and we're planning for that. And so just know that we're going to do a lot of this virtual stuff. So again, being able to use your video so that we can interact and ask questions and call on you. Know that, like, if you're in a dim lit area, we can't really see your face, so we don't know if you're there or not, or sleeping or anything. I know it's hard, like, y'all want to probably just like kind of hang out and stuff, but if they can't see your face, then it, like, a lot of times, like, if you're like this makes you look like you're just bored with life and don't want to be there. And not that any of you are intentionally trying to do that. That's why I might have side message like, hey, get your hands out your face, because I just didn't want them to feel like they were wasting their time. And y'all don't realize that that can look just like a disinterest look. None of us realize that, because we're just getting used to this platform of video type stuff. So just, we're all in this learning curve together, figuring out these little things like this, so I mean, I'm still trying to, I got to put a curtain up behind me because this is so much going on behind me, or turn my desk to the other more bland wall, one or the other. So dining room decor for this. So well, I hope y'all all have a great weekend, and I hope it's still nice weather, this crazy cold weather, so we're having a longer spring. I don't know what's going on with that, but I'm okay with it. So y'all just, again, stay in communication with me about things, and just email me, and I'm probably not as fast as I used to be with getting back to emails, because it's a lot over here and craziness. But we'll get back to that for y'all. So, okay, well, y'all have a good one. Yeah.